Okay. Hi, everyone. I'm Lia Talozzi, and I'm here to talk about the project I'm working on. It's called Latent Disconnectome Prediction of Long-Term Cognitive Symptoms in Stroke. So we are dealing with patients who had stroke, and we are creating a model to predict cognitive symptoms in a long term at 1 year after the stroke onset. And it's called latent disconnectome prediction, since we are using a technique called dimensionality embedding, where we are applying a data variability modeling through dimensionality reduction, and seeking for these latent patterns that can be associated with cognitive symptoms, to then be able to predict them for new patients. And I'm gonna show you how we are trying to create this model. As first, I would like to start with this kind of historical introduction about morphospaces. This is the word that I'm gonna use this through the presentation. Since the morphospace was used at first by Francis Galton in the late 18th. He was a statistician, and is first introduced questionnaires to acquire data that then he projected in a Cartesian space, as you can see in the middle, for the age of parents and adults, children, and see if there were correlations between the measures that it was taken. So the first step is to acquire data, then to seeking for correlations in a mathematical space, so in a diagram, in a Cartesian diagram. And then what's the third step? The morphospace. So when you want to modeling data that have a complexity, for example, the shapes of the face. So what you need to do if you want to create a model that it's going to be universal? You're trying to extract features. And these features are what maximize the variability of, in this case, the different shapes of humans. And you can see here from panel 1 to 4 how there is a geometrical abstractions of these shapes. And as Galton said in his Nature paper in the 1907, he was able to apply this method to all the portraits he has been through. So how a model can be a generalization of data variability to describe, in this case, the shapes of the face. And so it's called morphospace. So you are projecting your data in a space, and in this way you are doing a dimensionality reduction, since you are using less features that can be modeled in a, for example, a 2D space. No, the next one. And so what happened when we have a stroke is present? So as you can see here from this lovely image from the Netter Anatomical Atlas, you can see that the brain is supplied by cerebral arteries that can be divided according to the different territories, the posterior in green, the middle in red, and the anterior in yellow. So the brain works through the help of the blood flux, the nutrients, the oxygen exchange, and this is really important for the brain functionality. It's the nutrition of our brain. When a stroke happens, as you may know, we can have a leakage or a damage, a local damage of the tissues. And these can be studies seen using brain imaging. You can use CT scanners, so computer tomography using X-ray. And as you can see in this image that I taken from a book recently published in this chapter by Dr. Forkel. And you can see that in the CT image, the contrast between the brain tissues is not so defined, but as you can see, the arrow is pointing an area of hypointensity, where if you compare to the contralateral side, in the signal is attenuated for the stroke. And then if we study the same patient with MRI, you can see that MRI offers this wide range of contrast. Indeed, is a technique that at first can be difficult to understand, since is multiparametrical, so it can provide you a lot of information. Then at the beginning can be disorienting, but it's really precious information, so rich information that you can use to understand what is really happening in the brain. So in the T1 images are called more structural, because you can really see, as you can see, the resolution is higher, the contrast between the gray matter and the white matter. And where the arrows are pointing, you can see signal alterations due to the stroke. Then the tissue, you can see highlighted, so brighter, the pathological areas. And then you can use arterial leveling technique for the perfusion, so see that the areas where the stroke happen are hypoperfused, so hypointense in the perfusion contrast. Or you can study the diffusivity of the tissues, and so there is an upper intensity. And the FA is the fractional anisotropy. So you can see that there the diffusivity is not so anisotropic, so not defined in one direction, but is more isotropic, more widespread due to the tissue damaging that alter the microstructure of the tissues. So going to the point, we are interested, so MRI can provide a lot of information about the strokes, but in this case, we are focusing on white matter. So as you can see, here on the right, there is a patient, and the stroke lesion is segmented in red. So through this stroke lesion, white matter tracks pass through. And you can see here represented in a 3D, where you can see the white matter fibers passing through the lesion. And we are interested in modeling this information, and to see how the disconnections, so the white matter tracts that are damaged by the lesion, can be correlated to cognitive symptoms. And for doing so, we used the BCB toolkit, that is the freely available software developed by Chris Flon, Michel, Schotten, and colleagues. Here, as you can see in this pipeline schematization, you have the patient with a lesion, and this patient is aligned to healthy controls tractography data. Since when a stroke occurs, as we saw in the slide before, there are damages to the tissues, and this can make difficult the reconstruction of white matter tracts that are damaging. So we are using an escamotage using the healthy controls tractography data to quantify disconnectome maps, so probability maps of disconnection of the white matter tracts passing through this lesion. And this will allow us to run patient statistics. And as has already been shown by Michel and colleagues in this publication, Nature Communication 2020, lesions and disconnectomes can be embedded, so the variability of this data can be projected in a 2D space. Here you see the comparison between stroke, so real stroke data in red, and a synthetic reshuffling permutation of lesion stroke localization, to compare if this embedding technique can provide an information that a distribution meaningful for the data variability, or is just random, as according to the synthetic distribution. As you can see, for the lesion embedding in panel C, the embedding has been performed using the TSNE method, the T-distributed stochastic neighborhood embedding. So a way to modeling data variability. Here you see a 3D distribution, and you can see that the red lesions are more clusterized compared to the synthetic ones in blue, and this tendency is much more prominent where you are embedding the disconnectome data. And using this information in this article, they then correlate the different disconnections with functional activations to create a atlas of function and behavior related to the white matter disconnections. And we are following this path in the project that I'm going to show you. So as first, we will define a disconnectome morphospace, so an embedding of the disconnectome data. Then we are gonna will correlate the neuropsychological score at 1 year from the stroke onset with the disconnections in acute, to see if we can predict those scores. Then we also will create a white matter neuropsychological atlas to see where the predictions of the clinical outcomes are related to the white matter structures. And then I'm going to show you how this model can be translated into a web application that will serve for clinical research studies. So to doing so, as Galton started to do, we need the data, we need to collect data. This is a data-driven approach. So for the disconnectome morphospace creation, we're gonna use the dataset 1 that has been acquired at UCL London, and it contains more than 1,000 strokes data, so a rich data set, and you can appreciate how the lesion distribution is equally distributed bilaterally. And then for the neuropsychological correlations, we are going to take advantage of these second and third data set that were both acquired in Washington, and they contains different patients. So data set 3 will be an out of sample data set that we are going to use for validate the model that has been built using the dataset 1 and 2 to see if there is an agreement for new patient application. For doing so, we need a low dimensionality embedding technique. And we used the UMAP method, the Uniform Manifold Approximation and Projection method for dimensionality reduction. As you can see here in this image, compared to the TSD that I told you before, it allows a better segregation of the data structure. It's the more recent method that also computationally is more stable. And so it has like some improvements compared to the TSD. This is why we chose it. And also we were able to save the embedding transformation for applying this transformation to new data set, as I'm gonna show you. And this is, so when you're applying this embedding, this is the two-dimensional space that we obtain for the dataset 1, so more than 1,000 patients. And you can see we obtain this kind of triangle distribution. Here I highlighted a few patients, so each dot in this diagram corresponds to a patient, and you can see as the patients on the vertex, so about UMAP coordinate 7, UMAP coordinate 1 equal to 7, and UMAP coordinate 2 equal to 11.7. So in the middle and the top of the diagram, I presented a cerebellar region, and the disconnection in this probability map through from a lower probability to a higher probability in yellow, and to look more closely how this distribution obtain means. Here again the patients that I highlighted, and I also colored the different patients accordingly to the probability of the most disconnected tract. So as you may know, major Y-matter tracts are, for example, the corticospinal tract, here in blue shaded, that you can see is disconnected in this middle upper part of this pyramidal shape. The inferior frontal occipital fasciculus in orange shaded, that is more present as disconnected in the patients, more in the bottom lateral corner of the distribution, and in this little occipital areas where, for example, one patient is highlighted on the left side. So about embedding dimension 1 equal to 3, let's say, and embedding dimension 2 equal to 9, this occipital area disconnected, and the arcuate fasciculus in green shaded, more present in the central areas of this distribution. And we have this symmetry between right disconnection on the left half of this embedding space, the disconnectome morphospace, and the left disconnection on the right half of this space. And as I was saying, the UMAP method allows us the saving the transformation, so the projection in this disconnectome morphospace. And so we apply this transformation to the dataset 2, and here you see highlighted how patients with similar disconnection patterns are projected nearby across the different datasets, and the same for dataset 3. So this method allows us a generalized modeling of the disconnections in stroke that we create for the dataset 1, and we applied for the new patients, in this case dataset 2 and 3 that we are going to use them. So as I was anticipating, for the dataset 1 and 2, a large battery of neuropsychological scores were acquired. As you can see in these lovely illustrations by Dr. Pacella, about motor functions were acquired. We have in total 15 scores, for example, related to grasping, gripping, pitching, or the strength of the grip task, the 9-pole peg test, the shoulder or wrist flexion. So a comprehensive motor battery to quantify clinical score, neuropsychological scores, in this case acquired 1 year since the stroke onset, so in a long term. Also, scores related to language were acquired as the verbal fluency task, and where it's asked to naming the different animals that you can think about, or the Boston naming test, where it asks to name some images that are showed to the patient, and also visual spatial attention scores were acquired, here in illustration of the subministration of the Posner oriented task, where different cues are present, and the patient is asked to indicate where the target is for visual spatial attention information. Also, visual spatial memory data were acquired, verbal memory data too, and also a Sickner questionnaire was administrated relating to 2 axes of sickness, one more related to the physical sensations and task, one more related to the social behavior of the patient, and the one pain score recorded for the scanner session. This illustration have been provided me and created by Dr. Forkel and Michel with the Schotten. So we use we correlate each of these neuropsychological scores to the localization of the patient in the morphospace. So here you see in the background an R color map, so Pearson correlation scores for each pixel in the morphospace. So we have both negative correlations in the blue and positive correlation in red, and there are highlighted with black borders the correlations that were higher than 0.2 in a module value, so both negative then or positive. And you can see for motor score, for example, the left grasping from the ARA battery, as you can see, the negative correlations were really clusterized on the left corner, left bottom corner of the morphospace. So the disconnection, the disconnectivity patterns of the patients were embedding in that area and are correlated to negative scores, so lower performance in the grasping test. Whereas for the Boston naming score, you see that the distribution is not so so net divided for the motor score, but is there is a more complex pattern. Indeed, different disconnection embedding in different clusters, in different risk territories of the disconnectome morphospace can lead to the same neuropsychological score, the Boston row. In this case, the lower scores, the correlation that we can see highlighted in blue, were more present on the left disconnectivity patterns that here are embedding in the right half of the morphospace. Whereas for the Posner disengage accuracy test score, you can see that the distribution is even more different with this lower R correlation in so negative R correlation in both the bottom corners of the morphospace. So we are going to use this information, these pixel-wise R correlations between embedding coordinates of disconnectomes patterns in the morphospace with neuropsychological score to predict, to create a model that allows us to predict new patients' neuropsychological scores. For doing so, we create this pipeline. As first, we created this probability of localization for each patient. So not just one dot, so two coordinates, but a distribution related to the patient that allow us to characterize the localization with the patient with an uncertainty in the data projection, the disconnection segmentation. So we use this distribution where he's higher in higher going through the red, dark red to yellow. And we did this for each patient. And then we unroll the morphospace pixel in one vector And here you see this matrix representing in the different columns the different patient data, and in the different rows the disconnectome morphospace pixels. Here I just represented the 300 pixels. This information were used to run the correlations that here you see reported only the ones that survive to the 0.2 threshold, both negative and positive. And then to summarize the patient distribution in these risk territories area, so where the correlation were higher than 0.2, we used a principal component analysis to obtain 3 scores according to the principal components that are going to be the variable of a multiple regression model where we are predicting neuropsychological score of different patients at 1 year. So this is a different step of abstraction, so modeling of the disconnectome patterns to then create a formula where new patients can be imported and used to predict neuropsychological scores. And we did this with the dataset 3, so importing new patients. And here I reported an accuracy score to see how accurate were the formula prediction. And in this score, we evaluated the error, so the difference between the measured score and the predicted one. And we normalized this error basing of the maximum value obtained in the score performance. And we then subtract this error score, error percentage score to 1 to obtain the accuracy of the prediction. And here I reported the different accuracy for motor scores and language scores. You can see that 64 scores out of 87 presented an accuracy that was higher than 80%. On average, the accuracy was 83%, plus minus 7. As you can see here, for the motor scores, the average accuracy was about 87. For language score, 88. And you can see how some scores were above this average, others were under, and so the distribution of the accuracy across the scores. Also, since, as I show you, a large battery, 87 scores were acquired, here I propose you this kind of a visual inspection of the difference between the predicted score on the in the left matrices and the measure scored in the right matrices for the different domains that we explored in the neuropsychological data acquired, so motor, language, visuospatial, attention, visuospatial memory, verbal memory, pain, and sickness in a normalized scored according to the maximum of the recorded measure for each score. And you can see visually the agreement between the prediction and the measured scores. Then we would like to do a further step. So trying to correlate these territories in the morphospace that were informative according to the different neuropsychological scores with white matter localization. And for doing that, we used a randomized model using the FSL library code, where we correlated the PCA scores that, as I told you before, were used in the prediction model to correlate these scores with the localization of the different disconnectomes. So each scores obtained, in this case, we used the dataset 1 disconnectomes imported in the PCA multiple regression model correlated to the different scores. We used the dataset 1 since it's the biggest dataset, and we did a retest of this method, splitting the dataset 1 in two groups of 666 patients, and we obtain a reproducibility of this correlation of 0.82. And you can see here that the R scores that are highlighted in the morphospaces are related to specific disconnections in the white matter. So, for example, for the left grasping, you can see in the effect size color maps. So from medium effect size higher than 0.5 to high effect size 0.8, and you can see that are related to disconnection of the right in the right hemispheres, connected the operculum areas, the premotor cortex, superior temporal gyrus, the striatum pathways, whereas for the language, Boston Nemitas, you see highlighted disconnections through the external capsule and connected the arcuate branches connected to the superior temporal and middle temporal gyri. And whereas for the visuospatial attention, these two corners of the morphospace corresponded to correlations in the white matter involving the corticospinal tract, the corpus callosum, so commissural pathways reaching the insula. Also we have the arcuate fasciculus long segment branch, striatum, thalamus, and so a more complex and bilateral distribution of white matter correlations. In this manner, we were able to create an atlas, so a summary map of the neuropsychological scores. Here you see in the maps in panel A the highest correlations, so the names related to the highest effect size in correlating white matter disconnection and neuropsychological scores. And in the since not there is an overlap between the functions and the disconnections. In the panel B, you see the highest effect size of these correlations. So in this case, you see that is the higher is the highest is in the frontal connections on the left in the left hemisphere, And whereas, as I was saying, we have an overlap of the different scores correlations. And here in the dependency, you see you can see the versability maps. So how many scores were significantly correlated in that white matter areas. And in this case, you can appreciate a higher overlap on the right. And the next step was how translating this model to a clinical and research application. And for doing so, I'm creating this web application. So it's a software, an app that can be run online. So you will need to upload the disconnectome data, and the software will run the analysis in the web server and provide you the output that you can download and hear a preview of the prediction of each of the disconnect the neuropsychological scores that I showed you before. And this is a web application created in a Django framework. The Django framework is written in Python, so it was a good match for translating in a web application the Python scripts that I used to define the morphospace and then the multiple regression model prediction. So how translating this complex model using low dimensionality embedding in a simple web application where you just upload your disconnectome data of the stroke patient analyzed in acute and predicting the 1 year expected neuropsychological scores based on the morphospace predictions. So to summarize what we learned that we were able to embed the different disconnectomes in this morphospace, two-dimensional Cartesian space, and this is the distribution that we obtained. And we translate this model also to new patients to import in this model. And we also create a formula that allows us to correlate and predict neuropsychological scores related to the localization in the disconnectome morphospace. We then translate these to a white matter atlas of this neuropsychological score latent prediction in the disconnectome morphospace. And then we translate this model into a web application for an easy deployment and transferability of this model. Of course, as I show you, the average accuracy of the prediction was 80%. So we are missing the interpretation, the description of a 20%. This can be related to the different interindividual differences, to different neuroplasticity mechanism in act, and to some, as I show you, MRI provide us different contrast, and we didn't consider, for example, the hypoperfusion of the tissues, or you can also look to the hypo metabolism using PET. So some data variability that are not captured by the disconnectomes. But a good amount of variability, we were able to assess. And of course, I would like to thank all the collaborators to this project. It was not possible to create it without them. So our group leader, Michel Schotten, Parashkev Nachev, Maurizio Corbetta, Stephanie Forkel, Valentina Pacella, Vicotr Nozais, and of course the grant sourcing from the European Union, the ERC disconnectome grant we are working on. And this is the image from the Vicotr Center here in Bordeaux, where I'm located. And yes, I also would like to thank you for this virtual attention that you're gonna provide me when you are watching this podcast about the disconnectome project I'm working on, and I hope you enjoyed. And please let me know if you have any curiosity or other questions related to this project. Thank you.